Welcome to another talk, another edition of Doc Talk, where we have eminent specialists who come and discuss the various aspects of rehabilitation at Sukino. This time we have Dr. Harsha Narayanamurthy, who is one of the leading and eminent neurosurgeons in Bengaluru with over 17 years of experience and with special focus on cranial, spinal and pediatric neurosurgery. Dr. Harsha is a consultant neurosurgeon at Kauvery Hospital's Electronic City. This time we will be discussing about neurotrauma, other cases that are very special to him, how he takes care of the patients during the stay in their hospital, and how he follows up on the patients further during the neuro rehabilitation journey. Welcome, Dr. Harsha.
Thank you. Pleased to be here.
So, how would you define neuro rehabilitation, and what kind of people do you think can benefit from neuro rehabilitation?
Well, thank you. It's a very broad question. The reason for that is obviously with my specialty as a neurosurgeon, we know that neurological patients or neurosurgical patients, they tend to develop neurological disability and morbidity.
Right.
And that's a huge burden on society where people struggle through neurological illness. It is often described, other medical specialties deal with life and death. The neurosciences, we deal with life and death and something in between, which is disability. And that is a real problem because it not only affects the patient's physical health, it also affects their mental health.
Right.
It affects their sense of identity, their idea of self-worth, if you will.
Right.
And their pride in how they do things, how they approach life. And rehabilitation it's long been a concept since times immemorial that there were certain switched on physicians who knew just providing acute intervention was not enough. There is a whole phase of improvement afterwards that could be worked upon, but the concepts were always nebulous. And in the last 30 to 40 years, I think things have really come to the forefront where neuro rehabilitation can now rightly be considered as an emerging specialty in its own right.
Right.
Now, one of the things that we start focusing on in the hospital, straight away, as soon as someone comes in with a neurological injury, either I could take the examples of a few conditions like stroke, for example, where people come in with significant neurological morbidity.
Right.
They have lack of movement down one side sometimes, lack of speech, or even worse, the ability to understand speech. There are patients who come in with traumatic brain injuries where all forms of neurological disability can happen.
Right.
And that is wildly unpredictable and sits on a large spectrum. There are patients coming with spinal injuries who have neurological disability mainly in the limbs. They can have weak legs, loss of sphincter control, for example, weak arms if it's a neck injury. And you have patients who come in with tumors in the brain or in the spinal cord, which causes similar problems to trauma and stroke. But the nature of that disease is a bit different, right? So you've got to approach it a bit differently. And then you have other smaller things, luckily, like iatrogenic problems where we provide intervention and unfortunately it doesn't go as ideally as we would like.
Right.
Some patients suffer complications and problems and they have to be looked after as well. So our rehabilitation plan starts from day one after an intervention, like an operation or thrombolysis, clot extraction in strokes. And then we assess neurological status before the intervention. We assess it immediately after. And then we start formulating an idea what this patient might need. If a patient does not wake up completely pristine after an intervention, you already know they're in for a journey.
Right.
Because neurological recovery does not happen straight away. It does not happen like that. People don't just get up from a stroke and walk. And since we know that, and we also know that loss of language or speech takes much longer then physical rehabilitation.
Right.
We start focusing on that too. So in the acute phase, you start working on whether they can actually swallow and produce sound at all. And the next thing would be whether they can actually understand speech.
Exactly.
Because that is the basis for producing speech.
Correct.
And then you work out how much of a movement disability they've got. And that would then tell us whether they are likely to be bedridden or they have some ability to immediately mobilize.
Right.
And whether we can get them out of bed and start exercising them. We all know now from the modern concepts of recovery that early mobilization is key.
Exactly.
There used to be a concept where after a spinal injury, for example, patients used to be placed in flat bed rest for weeks and weeks.
Correct.
Now we know in retrospect that is not probably ideal because it leads to lots of complications. And early mobilization using effective adjuncts and getting them to a specialist who focuses on their recovery is absolutely key.
Right.
Yeah, please.
You couldn't have put it in more detailed way. You have described the whole neuro rehabilitation in a nutshell. So as a neurosurgeon, the golden hour is very important to you. That is where you save the life. The moment rehabilitation, like you say, rehabilitation starts the moment when you start treating the patients. So probably when you have a patient who has undergone a neurological surgery, you might need to protect their airways with a tracheostomy. You might need to find a way to feed them in a natural way. You need to drain the urinary tubes and think properly. So the plan is already set in your operating table. So subsequently, once the patient starts showing signs of recovery, depending on the lacunae that you find with your patient, you will be designing some primary goals for this patient. What would be the immediate goal that you want the patient to attain in your ICU before you can consider them for the next phase of rehabilitation?
So in terms of planning their recovery, I mean, what we would like to see is the immediate movement, limb movements. That is something we always try to assess early doors, because motor movement probably, it might sound a bit odd when I say it, but it's probably the easiest to regain.
Right.
The other things are far more delicate, like, for example, in a spinal injured patient, the ability to feel the ground beneath their feet. You've got to retrain them to look out for these sensory cues, because sensory improvement is not going to be that immediate. But the last one is the speech and language. And that is a very interesting and often ignored part of recovery. And that is mainly because my focus is on the understanding part of it. I find it fascinating how the brain tries to cope. And you already see strategies developing in the patient's mind because they cannot understand speech.
Exactly.
They already ask for a writing pad if they're able to read and write. And when they start showing these signs of wanting to improve, that is when we start saying, right, you've got potential, because you're already showing signs of an insight into the problem.
Right.
They've already realized that they are up against a challenge. And then when we find that they can actually understand our speech, we can explain to them. So I take some time in explaining to the patients, look, you've had this kind of an injury, this is the problem, and we expect that your recovery is going to be a bit long drawn out. You're going to have challenges. We're here to back you up and support you. You will be doing all the hard work.
Good. That's great. So once the primary goals are set, your team will be looking at weaning the patient off the ventilator, starting the feeding, getting the patient to mobilize. There will be certain mechanisms engaged to prevent further complications and prevent further infections. That's when our team gets involved. We do a formal assessment. We take over the clinical details from your team. We have the so-called functional independence measure scale, where we evaluate a patient to see what really are the lacunae and what can be identified. So that sets the tempo for our next phase of therapy. I'm sure there are a lot of techniques that you would advise your patients and our therapists would follow from the neurosurgeon. What are the techniques that you would like to employ in the early phases of rehabilitation?
So I think I think specifically to employ precise techniques would be a bit difficult
Exactly.
in the immediate aftermath of, for example, surgery, where they might not actually be able to engage with any such specific focused programs. So what I tend to focus on is to keep reminding patients about the specific movements they still have left and the specific targets that we're going to set for them for the future.
Right.
And I say to them, I mean, to give an example, I think examples work really well. Someone who's got hemiparesis, for example, what we tend to do is we tend to make them use the stronger side first and then tell them, look, you remember this is how the movement should be. Now try the other side.
Right.
And when you try it, and they can actually, one of the interesting things I do is I hold the arm up in front of the patient's eyes so they can actually see it, because
Right.
they may not be able to feel where it is in space. The spatial orientation is a bit lost. I tend to put it up in front of their eyes and say, I need you to look at your hand and start moving it. Simple movements, keep focusing on that, keep the goals very simple and achievable, and then focus on the next step.
Wonderful. Wonderful. You put it very eloquently, how to identify the needs of the patient and to define the capabilities that will set the tone for the next phase of rehabilitation.
Yeah.
Now, what are the common challenges that you normally face at this phase?
So if we are talking about the immediate aftermath of an operation, for example,
Right.
or the acute phase of their injury, the challenges from a rehab perspective is, A, the patient might not be in a sensorium enough to allow them to focus on it.
Right.
Or they may not be in the mental space to focus on it. They're still trying to internalize the fact that they've had a major injury. It is life-changing, and they are faced with a huge challenge ahead of them. The headspace doesn't exist, and we've got to make them push through it, see through it,
Right.
to say, yes, you can still do it. That becomes a big challenge.
Right.
Of course, I can't say enough about the acute medical problems we face and they face, where they have chest infections and DVTs and pulmonary embolisms, recurrent neurological injuries,
Understand.
bleeds into the operative area. I mean, these exist. That's what we're here for. We look after them.
Yeah.
But to get the patient's mental status and framework from the acute injury to beyond it, saying we've identified a challenge, we've got to work on it. That is the real difficulty.
Wonderful. So you have very clearly laid down the path of an individualized plan for a patient, identifying the needs, the anticipated complications. That's when our team gets in touch with your team to understand the needs of the patient. There are general physiotherapists who concentrate more on the speech and language pathology aspect, people who concentrate on the respiratory therapy, as well as people who concentrate on the occupational therapy, depending on the neurological condition of the patient.
Yeah.
Many a times the patient would have gone through a lot of distress in the preceding days and weeks. They need some kind of psychological counseling to understand. So I'm sure like these three people would help your subsequent team to take care the further rehabilitation to the next step, where people can focus for the next several weeks and months together. Now, how long do you normally anticipate a neuro rehabilitation depending on the initial injury? What could be the timelines for their recovery?
That's an excellent question. I think that is something that is still not completely established in evidence.
Right.
However, the traditional wisdom is any neurological injury, I always say, it is not a linear progression. The improvement is always a stepwise progression. So patients need to be told very clearly, you might see a bit of early improvement and then it plateaus off, and then you make some more improvement and then it plateaus off again. And the other thing is, let's take the example of a stroke. Traditional wisdom would always say the recovery would not be considered complete, or you wouldn't say they would not improve any further until they're about a year to a year and a half out of the stroke. Similarly with spinal cord injuries, sometimes, depending on the grade of the injury, and I'm sure there are many people who talk a lot about the exact grade, but the main thing is if it's a complete spinal cord injury,
Right.
then the scope of recovery is very, very, very minimal.
Right.
But if it's an incomplete injury, then obviously the first few months are critical, after which any further progress after, say, 6 to 8 months would be an added bonus.
Understood.
The brain has a lot of plasticity. It recovers much better sometimes. The spinal cord, unfortunately, does not have the same amount of plasticity.
Right. So, if I could understand this properly, you have elaborated on the neuroplasticity and where are the conditions that it could be useful and can be anticipated or further dwelled upon for certain kind of patients. Now, would you like to elaborate, like with the advancement of digital world, the arrival of artificial intelligence, the use of technology, robots, exoskeleton, hydrotherapy or aquatherapy, and then would you like to elaborate a little bit more on these advancements or what new technologies are available for people seeking neuro rehabilitation?
Certainly. I mean, I think as a neurosurgeon, whilst I don't dwell extremely into the painstaking details of the most modern advances, I certainly keep my finger on the pulse of what's going on. In terms of spinal cord rehabilitation, for example, we have certain very exciting new developments where people around the world have developed an endo or an exoskeleton even, which can be powered by thought. That, I think, is a futuristic concept where there is an interface being developed between the brain, which is completely intact in a spinal cord injury patient, and the exoskeleton. And they use that to provide impulses bypassing the interrupted spinal cord circuitry. And I think that is very exciting. I've seen some concept videos, and the patients, after a bit of training, can walk nearly normally. However, as I said, it is futuristic. Currently, I think the development is in the phase of they wear a battery pack and they wear certain remote pads which they can use with their arms to trigger the movement in the legs. And once they've been trained in it, it's quite seamless and it's very, very good. It supports the leg movement. In terms of stroke rehabilitation, again, I think the neural machine interface, there's a lot of research. For example, one of my colleagues in London, in University College London, he's a professor of neurolinguistics and human machine interface. He's been working on a chip to try and bring that to life. That would be an exciting development in stroke rehab, for example. So we have lots of things on the anvil which will improve the scope of neuro rehabilitation in the future.
You are talking about how a holistic multidisciplinary team helps in the recovery.
Yes.
To go further, like there are many medical teams that are needed in the recovery of the patient. You as the neurosurgeon, probably the neurologist, a cardiologist, maybe a general surgeon, depending on the complications the patients develop. We are adept in handling these kind of situations where we rely upon the expertise from your team to understand so that the patient is always at the safest of the hands. You also dwell more upon the non-medical aspects of care, which will help a person to recover very well. It nevertheless becomes more important to involve the patients as well as the relatives in this process. How do you see this going forward?
Well, again, another interesting question. Thank you. I mean, being of Indian background and having trained in the United Kingdom, I've seen both aspects to this, where patients are considered individual and they are involved quite a lot in the Western countries with their care. They're very well aware. But I suspect somewhere along the line, the extended family and friends being involved has not been quite so much. Whereas in India, I think we've still retained the concept that it takes a village not only to raise a child, but also to look after someone who's vulnerable and needs help. I think it is extremely important for us to take the patients and their family along with us,
Right.
because they form, I think, the biggest mental security blanket for a patient. They are the ones who sit with them through the night. We might be very switched on caregivers, but we're not there 24 hours with them. It's the loved ones, the family. They are the ones who stay with the patient. And so I feel instinctively it's very critical to educate the patient and their family together.
Right.
You give them a clear précis of what is going on, what is to be expected, what are the challenges that are going to face them, and how they can actually help. I think that is one thing we can develop on. I've noticed that we've become good at giving information to the relatives. We are yet to improve to an extent on what they can do to help. I think we can certainly dwell on that later on if there is time.
Understand. So you very elaborately described how to address the emotional and the psychological needs of the patients as well as the family. Going towards the conclusion, I understand that you had a lot of journals in the British Journal of Neurosurgery as well as the World Neurosurgery and the Neurotrauma journals. Would you like to elaborate some research that sheds some light on neuro rehabilitation per se?
So it's due to the nature of what I do related to acute operative neurosurgery, the chances are a bit limited on my research or my interest focusing on neuro rehabilitation. But obviously, I've had excellent colleagues who are very heavily involved in these rehabilitation journeys. And one of the interesting concepts is speech and language development around a topic that's close to my heart, which is tumor surgery. And there are a couple of papers that have been published from the UK about the differences in neuroplasticity and neurorehabilitation of patients who are monolingual and bilingual or multilingual. And it's a fascinating study that shows very clearly and supports research coming from the stroke world about bilingualism and multilingualism, where the recovery is much better if someone is trained in different languages.
Right.
And there is some emerging evidence which says even after a patient has suffered a neurological injury, if they start training in a new language, they don't have to learn it in detail, they don't have to learn it in excruciating grammatical accuracy, just trying to learn some words.
Right.
It seems like it switches on something in the brain and there is parallel processing happening, and that triggers new synapses, new connections, and a much better recovery overall. And we've seen that in specific things called supplementary motor area injury after tumor surgery, and people who are able to move their arm, but they've forgotten how to do it. The process of moving arm from position A to position B in a seamless, smooth manner. The SMA, which coordinates these activities. As soon as you start training them by using both hands, training them to be ambidextrous, again introducing some parallel processing, they suddenly are better able to do it. And I've had a few examples in my own patient population where this has come in handy. And we've tried mixing language rehab and SMA rehab, and that seems to work amazingly well as well.
Amazing.
So yeah, there is lots of exciting development in rehab.
You couldn't have put this better. I do understand that the possibilities are not limitless following a stroke, but then one need not be constrained with the limitations one has, and they should explore all possibilities of a very varied neuro rehabilitation. As we conclude this talk, a very fruitful one, a very insightful one, would you like to share any of your success stories from among your patients?
I think, I would entirely agree with your previous statement that while the possibilities are not limitless, I think one cannot put a price on human dignity.
Right.
And I think neurorehabilitation is a space which provides a patient with neurological disability that precious, priceless thing called dignity. It gives them a sense of, I am back to being myself. I think nobody can put a price on that. Some of my best patients are those who have gone in with the idea that this is a challenge I can overcome.
Right.
We had a spinal injured patient who came in with a spinal fracture, and during the operation, unfortunately, the fracture moved and the spinal cord got injured, and they woke up unable to move their legs. But we had identified it, and we'd taken out the compression. We'd done everything to fix the problem, and we assumed, given that they were completely paraplegic, that the recovery might be constrained, it might not be complete. But the patient was very, very, very focused, saying, "You've done your best, now it's over to me, I'm going to do this." 2 months later, she walked in with a cane.
Amazing. That's amazing.
And you could have picked my jaw off the floor.
Yeah.
It was stunning. And there were a couple of patients after a stroke who were unable to understand, who were unable to speak. Only recently, I think, one of my patients was in rehab after a hemorrhagic stroke. He was unable to understand a word of what was being said to him. Very educated man in his 70s. Now, 3 months down the line, I've seen him in my clinic 2 days ago. He's sitting there going, "Oh, I need to show you something." Well, he got up, walked around and said, "Say something to me." So I said, "Well, how are you?" "I'm very well. I could not do this 2 months ago, could I?" It's stunning. Amazing effort. I think that just goes to show concerted effort between the patient and the neuro rehab team can do wonders.
Wonderful. Reinforces the fact that we should never lose hope. It's been a pleasure having you, Dr. Harsha.
It's been an
Looking forward
absolute
to
pleasure being here.
Thank you.